Greetings, everyone. Good morning, good afternoon, and good evening. And thanks to everyone for joining us today for this Children AIDS Learning Collaborative webinar on ICASA and IPHASA. My name is Rikke Kierkegaard. I work as program specialist with UNICEF, and I will be your host today. So today's webinar will provide a summary of the newest science and learning on children, adolescents, pregnant women, and HIV, which was presented at the International Conference on AIDS and STIs in Africa in December, and then the first International Pediatric HIV Symposium in Africa, which was convened for the first time in November. The IPHASA is a new scientific symposium that will precede every ICASA conference, and we are very fortunate to have the founder and the chair of IPHASA present the summary for us today. Dr. Eleanor Namusoke-Magongo is a pediatrician, and she's currently working as team lead for pediatrics and adolescent HIV care and treatment at the Ministry of Health AIDS Control Program in Uganda. And in addition to IPHASA, Dr. Magongo has also initiated and led the coordination of the Pediatric Adolescent HIV Learning Collaborative PAHLCA, which is a forum for HIV program managers to share best practices and to really foster South-to-South evidence-based learning among countries in Africa. So we're very pleased to have her with us today. We have up to an hour for the presentation, which will be followed by Q&A. And before we move on to the presentation, I would like to briefly mention a few practicalities. First of all, please use the chat box for comments or any technical issues. Second of all, if you have a question to the speaker, you can send it at any time using the Q&A box, and we will get back to your question after the presentation. And then finally, the webinar is being recorded, and the recording and the PowerPoint, both for the presentation today, as well as a longer slide set, they will be made available online after the webinar on childrenaids.org, where you can also find recordings of previous webinars, and you can sign up for the Children AIDS Learning Collaborative. So without further ado, I will hand over to Dr. Magongo.
Thank you very much, Ricky. Kindly allow me to share my screen. Thank you. Thank you very much, Ricky, and thanks to the UNICEF team for organizing for us this webinar. I will dive straight into our presentation. This will be our presentation layout. I'll take us through the epidemiology of pediatric HIV, COVID-19 impact and service delivery innovations, DTG viral load testing, suppression, patient-centered care, and HIV prevention and testing services. Let's start with the epidemiology of pediatric HIV. This presentation was made by Dr. Chewe Luo, and she was presenting on looking back, reducing HIV new infections and AIDS-related deaths in children. As you can see in that first graph, as the number of patients or the proportions of patients accessing ART increased, over time, we have seen a reduction in the new infections. And we can see in the dotted purple area that even though we've made significant progress, we still have a challenge of the stagnation in our progress over the years. And moving on to the AIDS-related death and pediatric ART coverage, we see a similar trend. As the number of children or proportions of children accessing ART increased, we have seen over time that the global AIDS-related deaths have also reduced. However, as seen in the first graph, we see in that dotted purple area that over a period of about 5 years, we've seen a stagnation, and we need game changers in order for us to reach our desired goals. Let's move on to ART coverage in PMTCT, starting with the West and Central African region. We can see that we still have challenges here. And when you look at the different countries, it's just a few of the countries, actually Benin, that has been able to reach over 95% of mothers, pregnant and lactating mothers are receiving ART. And the regional average for maternal ART coverage in Western Central Africa stands at 56%. Moving on to the Eastern and South African area, we see a slightly different picture, with the more countries having maternal ART coverage over 95%. And even though we see a better picture here, we still see that some countries like South Sudan, Djibouti, Somalia, Madagascar, and Sudan are still struggling in this area. And the regional average for the Eastern and South African region stands at 95%, much better than the Western Central African region. So we see that the response here is uneven between regions and countries, with lower access in West and Central African region. So moving on to pediatric ART coverage, again, starting with West and Central Africa, we see that we have an even much lower access to pediatric ART, with an average of 36% in this region. In the Southeastern and South African region, we see a slightly better performance, with Eswatini over 95% of their children accessing ART and an average of 57% in this region. So we see again that the response is uneven between the regions and countries, and generally low access in both regions to pediatric ART. So let's move on to the COVID presentations that were made around the COVID-19 impact and service delivery innovations. This abstract was presented by Dr. Immaculate Mositia in Kenya, looking at HIV testing and positives identified in 22 PEPFAR countries. And you can see that slope downwards from 2019, when we didn't have COVID, to 2020 and 2021, when the COVID pandemic was raging all over the globe. And we see a similar trend among HIV positives, slightly better than the volumes of patients. The trend is not so sharp as in the first, as in the first graph, but we see that there's still a reduction in the HIV positives that were identified over this period when we had the COVID pandemic. So what strategies did this abstract present on ways we can improve case identification? These were scaling up testing for children living with HIV, referral of children from community for testing, outpatient screening for eligibility testing, HIV self-testing, looking at both assisted and non-assisted testing, and scaling up EID testing. This was a very interesting presentation made by Laurie Goulet, and she was looking at 4 areas of synergy created between the HIV and COVID-19 responses, which is very important because we know that once in a while, different countries experience different public health emergencies, and this is very important for us to note. So one of the potential areas of synergy is bringing services closer to communities by doing differentiated service delivery, looking at peer models, and also maximizing investments in the HIV infrastructure. Here, looking at strengthening laboratory systems. We also what happened, how countries quickly strengthen their lab systems to be able to manage the pandemic, and also utilizing the training approaches that we used during the COVID-19 period to scale up trainings that are pertinent in the HIV area. And very important, the strategic information. I know that most of us are aware that during the COVID-19 pandemic, there were different platforms that were providing real-time data on the COVID pandemic globally, but also within our different countries. So this presentation was reminding us that we could use these innovations that have come up during the COVID-19 pandemic to improve our HIV program. And of course, the robust supply systems that were implemented to make sure that the vaccines and the different commodities that were needed for the pandemic were in place. And catalyzing use of digital platforms to disseminate correct information through social media, telementoring, and virtual trainings. And lastly, strengthening a multi-sectoral response and to ensure that in our different programs, we bring the different line ministries, the different stakeholders to work together to improve our HIV programs. Moving on to multi-month dispensing of ART and viral load suppression for children. This was a study that was done in 3 countries, Nigeria, Tanzania, and Mozambique. And this was presented by Stephanie. And during the COVID-19 pandemic, we saw that countries expanded their multi-month eligibility criteria for receiving ART. And through a faster project that is PEPFAR funded, the team aimed to monitor the impact of programmatic shifts on ART service delivery. They were looking at children aged 0 to 14, and the multi-month durations were less than 3 months, 3 to 5 months, and 6 or more months. The baseline periods were October to December 2019 before the COVID period, and the end-line period was October to December 2020 during the COVID-19 times. So we can see the different number of facilities that were involved in the different countries, and the outcomes of interest were percentage change in overall proportion of ART dispensed at for multi-month, the multi-month category and sex, and difference in median viral load suppression rates across the facilities, countries, and gender, and percentage change in proportion of facilities with overall viral load suppression above 80%. And the threshold for good performance was viral load suppression above 80%. Sorry for the typos in the slide. So looking at the overall multi-month uptake, we can see that there was an increase in the proportion of patients receiving 3 to 5 months of ART supplies from 41% to 61%. And we also saw a doubling in the proportions of patients receiving 6 months supplies. Moving on to multi-month uptake by countries, we see that in Nigeria, there was a significant shift or change from 38% to 79% in the proportions of patients receiving 3 to 5 months of ART supplies. And when we look at this by gender, we see that there was no significant difference looking at the different, the 0 to 3, 3 to 5, and above 6 months ART supplies, but there was slightly a higher proportion among females who are receiving 6 months of ART supplies and above. In this slide, we see the median viral load suppression rates across the facilities, and we see a sharper slope for Nigeria. This is a very interesting slide looking at the proportions surpassing the 80% viral load suppression rates. And I want you to note that before the COVID period, you can see that there were about 16% of patients overall that were receiving, that had a much lower viral load suppression of about 2%, 0 to 20%, 2% for 0 to 20% viral load suppression, and then 14% for 20 to 40%. But we see that this almost disappears during the COVID period. And we also see a significant increase in the proportions that had 80 to 100% viral load proportion, viral load suppression from 27% to 70%. And again, we see a very interesting results here in Tanzania, where we had a change from 43% among facilities with a viral load suppression of 80 plus, from 43% to 92%. So what are our key takeaway messages here? That the expansion in the multi-month criteria for children led to an increase in the proportions of children accessing multi-month dispensing. This reduced structural barriers like lack of transport, all the reasons that our clients have for not being able to come back to the facilities for their refills. Those were removed through the expansion of the multi-month dispensing. And as we saw in the slides, this led to improvement in viral load suppression. And this is something that we should all be thinking about So there is need to assess the impact, further assessments on the impact of multi-month dispensing on viral load suppression with ART optimization, especially in the era of DTG. So this leads us to DTG viral load testing and suppression abstracts that were presented on this topic. And I would like to start with a presentation that I was looking at virologic outcomes and risk factors for non-suppression during a viral load scale-up in Zimbabwe. And this was presented by Makrumize at ICASA. So Zimbabwe started implementing viral load testing in 2013, but there was limited evidence on performance of viral load testing and groups at risk of non-suppression. So the team aimed to estimate viral load suppression for routine and repeat tests after enhanced adherence counseling and to identify factors for non-suppression. This was a retrospective cross-sectional study using data collected from 2014 to 2018. And the definition for non-suppression was greater than 1,000 copies per mil. So in this table, we see that the biggest volume of tests that were conducted were the routine tests, and this was at 86.2%, and a smaller proportion of tests for the repeat viral load test. Moving on to the factors associated with viral non-suppression for routine viral load tests, we see that adolescents, for the routine tests, adolescents were 3 times more likely than adults to be non-suppressed on the routine tests. And for repeat viral load tests, we see that young adults were 3.48 times likely to be unsuppressed at the repeat viral load test, and for adolescents, 2.76 times more likely to have a non-suppressed repeat viral load test. So from this paper, we note that there's need for more focus on subpopulations at the highest risk of non-suppression, and these are adolescents and young people. P. Mawara et al. Presented a paper on ensuring viral load suppression among children on ART, enrolled on ART in South Sudan's OVC program, Orphans and Vulnerable Children's Program. And the Achieve is a PEPFAR USAID funded project that operates at 8 facilities offering OVC services. And in this paper, they enrolled 449 OVCs between 1st March 2020 and 30th March 2021, and the Achieve staff monitored ART regimens, viral load suppression, and multi-month dispensing. So we see that over time, as we see, when you look at the x-axis, you will see that as the proportions of patients who accessing multi-month dispensing increased, over the different copiers, we see that we also, the country or the program experienced an improvement in viral load suppression. And on the extreme right, we see that during, because we know that for most of our countries, the COVID pandemic began around April to June 2020, we see that there was a slight dip, but as we went into the pandemic and with the expansion of the multi-month, like we've seen in the previous presentation, we see that as people took on as more, when we see that over the quarters, from April to June 2020, looking at the number of children that were enrolled in the OVC program, we see that we saw an increase in the number of children enrolled in the OVC program, and also an increase in the viral load suppression over the different quarters reflected on the slide. So what we learn here, that enrolling children in the OVC program is very beneficial in improving viral load suppression. So moving on to a presentation that was done by Rose Masaba from Kenya, looking at viral load suppression among children and adolescents with high viral load, and implementation of a standardized enhanced adherence counseling. So in this particular study, it was a pre and post study. The study population was children and adolescents with a viral load. They were focusing on children with a viral load of greater or equal to 1,000 copies. And this was a retrospective patient level data abstract from medical records, looking at a period of October 2016 to September 2018. And the standardized enhanced adherence package that was implemented was SOPs. They developed SOPs in standardized enhanced adherence counseling, training of the team that participated in the study, mentorship on standardized adherence counseling, and individualized case management. So looking at the results, we see that looking at the viral load at enrollment into the study, looking at the pre and post, we see that the median viral load was almost twice or 3 times higher at the during the pre standardization as compared to the post standardization period. This is very interesting to note that during the implementation of this package, before the implementation of the intervention, most of the patients were still taking NNRTI based encouragements where we want to move away from. And following the intervention, we see that the proportion of children who moved away from NNRTIs to more optimal regimens improved. So looking at other characteristics, we see that enhanced adherence counseling uptake by age also improved. When you look at the different 3 age categories here, we see that in the post period, most of the children, all the children that they were getting in this intervention, they were able to access enhanced adherence counseling, as opposed to the pre-standardization period where about 20% of the children would miss this intervention. So when we look at 3 enhanced adherence sessions that were completed, we see that this proportion also increased by 10% following the intervention. And very important as well, we see that the time to completion of the 3 enhanced adherence counseling sessions also improved. We know that in some of our programs, this counseling tends to be extended, but we see that following the intervention in this particular study, the time significantly dropped from 403 days to 133 days. So looking at viral load results after 3 enhanced adherence sessions, again, we see that there was an improvement in the median viral load here, having almost reducing by a half in the post standardization period. And lastly, we also see that the viral load outcome after the 3 sessions was much better in the post standardization period. This was a very interesting result that revealed that in it was looking at the enhanced adherence sessions completed, and we see, interestingly, that patients who had less than the 3 recommended sessions were actually 2.2 times likely to have viral load suppression. So the key takeaway messages in this portion or group of presentations on DTG viral load suppression, we see that in this era of DTG, it's still important to continue with the standard practices like psychosocial support. Psychosocial support, DTG is very good, but if we don't keep psychosocial support and the other care strategies in place, we will find ourselves going back to where we are coming from. And we also see that we need to conduct additional studies to explore the impact of multi-month dispensing on viral load access and viral load suppression. And very important, a patient-centered care is critical to achieving the third and 95. So let's move on to patient-centered care. So this was a paper that was presented by Jessica et al. And they sought to define person-centered care within the HIV treatment continuum in sub-Saharan Africa, and they wanted to develop a person-centered care framework. So they looked at clients clients accessing HIV treatment services or health workers providing HIV treatment services. The intervention was to describe HIV treatment programs or elements of person-centered care that contributed to HIV treatment uptake, retention, and of viral load suppression. And they also wanted to compare different models of person-centered care. And so they looked at different resources, PubMed, and as you can see on the slide, they started with 1,852 papers, and you can see that in the end, after screening out or excluding different papers, they finally narrowed down on 31 papers. So this slide gives us the populations that were looked at and the different person-centered interventions that were found in literature and the outcomes that were reported, the outcomes that the person-centered interventions were targeting or improved. So for adolescents, we can see that the person-centered interventions that were implemented in the papers that were reviewed were appointment reminders, missed appointment notices, having adolescent-specific clinics, community adolescent supporters, the peer-to-peer groups, having flexi clinics, like on Saturday, where they pre-pack the treatment so that the adolescents don't delay at the clinic, having group activities. We know that adolescents are very vibrant, and health workers using Ministry of Health checklists to provide adolescent-friendly services, and for those in boarding school, ensuring that they continue to get HIV and SRH counseling, ART storage while at school, and having health clubs and treatment linkage. And on the extreme right, you can see the different outcomes that were reported to have improved through the person-centered interventions. For the pregnant and postpartum women and their infants, we see that lay health workers provided clinic and home-based education, and also the reminders were key, and following up of missed appointments, and postpartum women receiving HIV care at MCH clinics. This was very important in retention, and we know that for many of us, we are implementing this in our programs, ensuring that our clients remain within the MCH clinic until the final HIV status. So in this paper, this came out very clearly as something that can improve the retention outcome. And then individual counseling to pregnant and postpartum women are provided over telephone. So moving on to women and men, generally, we see that utilizing expert clients to provide services like counseling and education, home visits and phone calls, ART refills, having expedited ART initiation for people with low immunity at the time they come into care. Again, reminders, this seems to cut across the different populations, and then adherence clubs using EMR reports to follow up missed appointments, cash transfers, flexi hours, especially for men, education workshops, And for families, we see that having family clinics where you see the family together and having individual counseling for parents and adolescents. So here we see that in the families, even if it's advantageous to see them together in terms of counseling, the adolescents still prefer to be away from their parents. So this is the framework that the team proposed, looking at 4 key areas: staffing, service provision, digital technology, and direct client support. So the next steps that were presented for this paper is to share and validate the framework among the implementers, to develop a facility-based tool that assesses the degree to which the person-centered services are implemented, and to consider modifying the framework to cater for prevention and HIV testing services. So moving on to a paper that was presented by Dina from South Africa. And here the team was asking a question: does a youth intern program strengthen HIV service delivery in Africa? And so they took on unemployed young adults aged 18 to 29 with secondary education but no work experience. And the study had a dual purpose: to improve employment prospects and also to support health facilities by providing extra temporary staff. The interns were divided into 2 categories: the program interns, the admin interns, and you can see their scope of work was also different. Looking at the outcomes of interest for testing, the team was looking at the numbers tested and those that turn out positive. For treatment initiation, the newly initiated, and also looking at timeliness in terms of ART initiation, and then the 3 indicators on retention in care, loss to follow-up, completing viral load testing, and viral load suppression at 6 months. So this study was conducted at 207 facilities, and almost 3 times the number of interns were placed at these facilities. So before I present the results, I just wanted to slightly explain what this graph means and how we'll interpret our results. So when you looking at the interrupted time series, the key thing here is that the higher the slope between the expected outcome and the observed outcome, the higher the more significant the results. And here we usually have on the x-axis the time period, and on the y-axis the outcome of interest. So when we look at the results, we see that clearly the highest impact, when you look at the slope of plus 24.5, it means that the slope was quite high compared to the different areas. And you can see that the highest impact was in increasing the number of clients that were tested. The highest impact of having the interns was increasing the number of clients tested. We also see some significance here in the numbers of clients that were initiated on ART. And for loss to follow up, we also see that this was significantly impacted with a reduction in the number of clients that were lost to follow up. And we also saw the paper also reported an increase in the number of clients that were accessing viral load testing. This study was also from South Africa, presented by Musa Maganye, and they looked at integration of differentiated model of care on HIV and non-communicable diseases, looking at treatment refills in and out of the facilities in South Africa during the COVID period. And this slide takes us through the different statistics. You can see that in South Africa, they have about 5.2 million people on ART. The diabetes prevalence has kind of stagnated, stayed the same over the years. And when we look at hypertension, we see there's an increasing trend from 2008 to 2017. So in this study, they sought to redefine the convenience of patients for chronic care to ensure that there are no more queues. And they had 3 different approaches that they were looking at, different models, having the facility pickup points. And these were pre-dispensed treatment by the facility pharmacy or a centralized dispensing unit. And they also had external pickup points that included private pharmacies, smart lockers, community points, and you can see a smart locker there, the Pele box, and also the adherence clubs that would take place at either the facility or in the community. So for you to be eligible to participate in this study, you needed to be 18 years and above, at least on treatment for 6 months, and stable with your viral load suppressed, and the HbA1c in the past 6 months was supposed to be less than or equal to 7%, and your BP controlled if you're hypertensive. And the clinician needed to confirm that the patient is eligible to participate in this study, and the patient also needed to voluntarily opt for involvement into the study. And it was important that they had no TB or medical conditions requiring regular consultations. So we see from this study that most clients preferred the external pick-out points, and this was 60% as compared to the 32% for the facility pickups and the adherence clubs. And when we look at the different conditions, those who are HIV positive and also having chronic disease, taking other chronic medications, either for diabetes or hypertension, and also those who are comparing with those who are taking only chronic medications, we see a similar trend or a similar a picture that all these patients in both arms are preferred to pick their medicines from external pick-out points. So this is really telling us that our clients prefer to come less frequently to the facilities. They prefer to get their medication from very convenient places. So we see that in South Africa, there was an increase in the number of patients that are getting their medication from external pickup points from 36% to 60%. So what we learned from this study from our colleagues in South Africa is that it is possible to integrate HIV and non-communicable service delivery services at both facility and community level. So the key takeaway points from this group of presentations from the person-centered care services is that there's need to integrate NCD services into HIV services, and very important as well to integrate NCD and HIV services into routine primary healthcare activities. And this integration should occur at both facility and community level, as we've seen in the last presentation or the last abstract that I have shared. And we need to continue to innovate on how to further bring our services closer to our patients, and our patients should be empowered to take charge of their health. So moving on to HIV prevention and testing services, Alex et al. Presented a paper on factors associated with sexual exploitation and transactional sex among adolescent girls and young women. This was a survey that was conducted in 2017. And looking at the characteristics of the adolescent girls and young women, we see that 38.1% had multiple sexual partners in the previous 12 months. 12.7% reported infrequent condom use in the previous 12 months. 11.5% reported having drunk in the previous 30 days, and 12.2% were HIV positive. Looking at the odds ratio and the characteristic variables, we see that those who had multiple sexual partners in the previous 12 months were almost 6 times more likely to experience sexual exploitation and also to engage in transactional sex. And those that reported infrequent condom use were 3.4 times more likely and to have sexual exploitation and engage in transactional sex, and 2.65 for the HIV positives, and 2.61 for those who experienced any violence in their lifetime, any form of violence in their lifetime. So from this paper, we learned that there is need to scale up and to strengthen HIV prevention interventions for AGYWs with focus on those with multiple sexual partners, infrequent condom use, and those experiencing violence of any form. So let's move on to a paper that was presented by Roma et al. This was conducted in West and Central Africa. They looked at HIV and key populations in the region, and they wanted to determine their experiences, the service provisions, policies, and best practices. So the objective of the study was to capture a realistic picture of experiences of key populations and the efforts to provide HIV and STI GBV services for them. And this was conducted in 23 countries in West Africa. They looked at 4 themes. The first theme was looking at experiences, needs and barriers, enablers and data and information. The second theme looked at service provision. And then the third, policies, strategies and plans. And then lastly, best practices to support service delivery. They conducted a desk review, administered online questionnaires, and the questionnaires were translated in different languages, and it was sent to 377 key stakeholders, and the countries below Cape Verde, Central African Republic, Gambia, Niger, and Sao Tome did not participate. So looking at the needs and key barriers for key populations, we see that the major need was condom programs, followed by peer outreach services and harm reduction interventions and the integration of HIVs and SRH services for the key populations. Moving on to the barriers, the HIV-related stigma and discrimination was one of the key or major barrier, followed by high levels of prejudice and moral loading and SGBV and fragile health systems. So what were the enabling factors that were identified in this study? Providing sensitization training for healthcare providers on key population services, ensuring that health services are available. And when we move on to the experiences by key populations in the healthcare settings, the major challenge they experience is verbal abuse by the healthcare providers, followed by patient neglect. So sensitization training for healthcare providers and providing access to services were the main enablers in this paper that was presented. This was another interesting paper that looked at Pink Day youth-friendly services, and the aim was to promote uptake of SRH and HIV services. This was presented by Kawina in Zambia, and they had 32% of adolescent girls aged 15 to 17 years old. 60% of these were 18 to 19 years old, who were 18 to 19 years old reported being sexually active, and only 40% had used condoms at the last encounter. And the project implemented a Pink Day intervention where the young adolescents and young girls came in to access SRH, HIV, psychosocial support services. And this was done through peer-to-peer sensitization and focus group discussions. So through this intervention, they saw an increase in the enrollment and screening of AGYWs from 9,600 to 15,000. We also saw a 39% yield among those who are tested, which is quite high, and 96% of the adolescents and young girls who were supported through this intervention were virally suppressed. And the lessons learned by Kawina, Paul, and friends were that demand creation increases uptake of SRH and HIV services. There's need for a one-stop SRH service center and need for capacity building to expand youth-friendly services at grassroots level. And this study was on oral PrEP, was conducted by, presented by Unia Mayanja. This was done in Uganda. They looked at preferences and uptake of oral PrEP among AGYWs in Kampala, Uganda. It was a 24 months prospective cohort study. They enrolled 285 HIV negative AGYWs, and these were recruited over a period of 9 months. They had follow-up visits conducted. It was a mixed method study, and optimal adherence was defined as having equal to or more than 90% adherence. So the mean age in this study was 20 years plus minus 2.2. 92% of the girls reported paid sex, and 20% had had more or equal to 10 sexual partners in the past 3 months, and 38.5% reported using hormonal contraceptives. About 30% had STIs, and oral uptake of PrEP was about 30.6%. So in this study, one of the key things that they highlighted was that these results highlighted great need for HIV prevention services that are tailored to the needs of AGYWs. So when you look at the oral PrEP cascade, we see that 184 AGYWs declined PrEP, and the reasons were low HIV risk perception in about close to 35%, and a dislike for the daily pills. So moving on to the factors associated with PrEP that were identified in this study, you can see that for those who had more or equal to or more than 10 sexual partners in the past 3 months were more likely. So basically those who had more who had more a number or multiple sexual partners in the past 3 months were more likely to take on PrEP. And this was followed by those who are separated or divorced, were 1.5 times likely to take on oral PrEP, and then those who had STIs. These findings were very interesting. You can see that when they looked at quantifiable and protective amounts of the PrEP, you can see that over time, the young girls and adolescents don't actually take PrEP when you measure this by taking off a blood sample. However, when you ask for self-reported adherence, you can see that a good number of them were saying that they are actually taking PrEP. So this is very important for us to have at the back of our mind as we implement our PrEP programs. Another study, very interesting, that was done in Uganda by Winfrey and friends. They looked at social harm related to PrEP used among AGYWs in a PrEP demonstration project. And they looked at a period of December to 2017 and July 2019. They looked at AGYWs aged 18 to 24 years, and they were given TDF3TC, and they collected data on adverse effects, adherence, sexual behavior, and social harm. And they also looked at the visits of the clients. So they enrolled 848 participants. 11 reported PrEP-related social harm, and they had 10 events as a result of their next of kins mistaking the PrEP for ART, and 45% who experienced social harm chose to exit the study. And when we look at the PrEP-related social harm, we see that most of 4 were due to were physical assaults, and then another 4 verbal assaults. This was another study that was presented by Abel and friends that looked at successful return of clients after an HIV self-test was given. And the challenge they wanted to address is how can HIV programs track use of HIV self-testing kits? So they trained peers, distributed the HIV testing kits, and the peers had a package that they implemented, and they screened clients, they recorded the kits that they were giving out, they were giving out, and they followed these clients by phone or physical tracking after they gave them the HIV self-testing kits. And you can see that they distributed 21,000 kits, and most of these preferred assisted HIV self-testing. In both assisted and non-assisted, we had more females. And moving on to the results, we can see that 2% of the results were HIV reactive with the HIV self-testing kit, and of those 393 clients who had an HIV positive, a positive result on the HIV self-testing kit, 98% of them were confirmed positive through the conventional testing, and almost 100% of these were linked to care and started on ART. So from this study, the team learned that 98%, they experienced a 98% successful return rate for HIV status confirmation following the distribution of the self-testing kit, and the ART linking and in ART, the linkage to care and ART initiation was quite good. So we learned from this study that peer-led HIV self-testing kit delivery should be considered at both facility and at facility level, and may further increase identification of undiagnosed people living with HIV who may miss testing through the conventional HIV testing approaches. So the key takeaway messages here are to strengthen the integration of SRH and HIV services, for uptake of oral PrEP is low among AGYWs at risk of acquiring HIV infection, and new strategies to address this gap are required, especially ensuring that they continue on PrEP, as we saw many of them drop off along the with time, and we need new strategies to address the low uptake, including addressing the PrEP-related social harm. I would like to end by acknowledging the UNICEF team for organizing for us this webinar and for the support during these few weeks, past months when we were putting this presentation together, and the study teams that presented these abstracts, Dennis Kalibala, our biostatistician here in Uganda, for the TA in adding the animations and highlights to the presentations. And lastly, I would like to end by reminding us that in order for us to reach the last mile in the fight against HIV, we need to wear our creative and innovative hats daily. And we should, on a daily basis, ask ourselves a pertinent question of what must I do differently today? Thank you very much. Over to you, Rike.
Thank you so much, Eleanor. This was really an excellent summary of some of the many scientific advances and the programmatic knowledge was presented at the 2 conferences. And I think we already had a rich discussion in the chat box, but I think it was really interesting to see some encouraging findings that we've been waiting for example, on co-adaptations related to MMD and viral load suppression, peer-to-peer counseling, etc. So we now have around 15 to 20 minutes for Q&A. And as mentioned, we will be taking all of the questions from the Q&A box, but you can continue to send comments through in the chat box. So please start sending through any questions that you may have. Meanwhile, I'll hand over the floor to my colleague Shafiq for a few programmatic reflections before we get started with the Q&A.
Thank you very much, Ulrike. And again, congratulations and many thanks to Eleanor for a real tour de force. For those of us that didn't attend ICASA and IPHASA, this was really a fantastic run through some of the key findings, some of the key studies, some of the key learnings that were presented at both of those meetings. And I think these presentations will, as usual, be available for those who wish to have them as a reference and a resource. So Eleanor talked about the many issues that were faced during the pandemic. She highlighted the fact that from an epidemiological point of view, we still have a long way to go, but that the pandemic was something of a black cloud with a silver lining, that there was work that was done to adapt and modify services that actually helped us and that can now enable us to build back in a different way and in a way that will build resilience into the systems for health and HIV and ultimately help us to protect children and families more effectively. I also want to highlight that some of the key learnings that were brought out by Eleanor include the importance of community. We've always recognized that community and people living with HIV are themselves an enormous resource. And I think the thing that we saw in the pandemic was that there was a willingness and a desire to engage in self-care by people for themselves, but also for the communities that they live in, and for their brothers and sisters in arms, as it were, who were also being affected by the pandemic. And I think that is an absolutely critical lesson that we need to take home, that really at a time when health systems were not in a place to be able to continue and maintain the services that people needed, it was community systems that stepped in. It was people living with HIV that responded, not only to make sure that treatment was continued, that services were maintained, but also to be on the front lines of the COVID pandemic itself. Time and again, we saw examples of how people living with HIV, especially young people, were the ones that were not only making sure that drugs were being distributed, but they were also spreading accurate information about COVID, about how to protect yourself from COVID, and also how to access vaccines, and the importance of accessing vaccines for COVID prevention. So I think to me, one of the take-home messages is that the strength that we have with us really lies in the community and in what people living with HIV themselves can do to help and support us and each other. So let me now turn to all of you and invite you to post questions that you wish Eleanor to answer in the Q&A box. We have one question that has come in on adolescent girls and young women. And this person has noted that adolescent girls and young women hardly access PEP, let alone PrEP, and that often this is due to health worker attitudes and the lack of information available. So how, really, if we want to revolutionize prevention, how can we go about creating a culture of sensitivity and non-judgment so that young people, adolescents, can feel comfortable coming forwards and saying, look, I've had a risky exposure, I need PEP, or I'm sexually active and I need PrEP to protect myself? Maybe let's start with that question. Eleanor, please share with us your thoughts on that topic.
Thank you very much, Shafiq. And that's a very good question indeed. As we saw in one of the presentations, the young girls were telling us, indicated that they were taking PrEP, but they were actually not taking the PrEP. And as Shafiq has said, it's possible that maybe they could not go back to the facilities for refills because of the poor health worker attitudes. So one of the things that we really need to do is to ensure that we sensitize healthcare providers through capacity building, and we demystify or take away the negative attitudes towards PrEP, because most times the health worker are going to associate this with being promiscuous, and this negative kind of attitude keeps the young people away, so they will not come for their refills. They will come to the clinic and tell us they are taking their medications, like we saw in the study. As they will self-report and tell us, oh, I missed just one dose, or I didn't miss a dose. But when you take the blood draw, it is actually 0, like we saw. The other thing, as you have mentioned, Safiq, is to ensure that we empower the adolescent girls and young women to step strongly into self-care. And this will be done, or can be done, through having very strong literacy programs where we empower the adolescents and young girls to be able to understand what it means to receive these services, why they are important for them, why they need them, and why they should strongly advocate for the services that they need. Thank you.
Absolutely, Eleanor. I think the key lies with the community themselves. And I think change happens as people start to advocate for themselves and making their own case so that they receive these services. I mentioned the importance of peer-to-peer support systems during the worst time of the pandemic. But you've done all of this reading, you've looked at all of the data that was presented at both of these conferences, a lot of information that talked about COVID. What are your key takeaways? What is the one thing that, or perhaps the two things that you feel are really important for us to mainstream and ensure that we make part and parcel of the normal way in which we provide care?
Thank you very much, Shafiq. Indeed, the intervention of peer-to-peer support is very critical, especially when we are dealing with adolescents and young people. And you saw in the one of the papers that were presented where they were looking at patient-centered care, one of the key things that came out was the peer-to-peer support for the adolescent and young people. So we've had many times the young people tell us that nothing for us without us. So, and we know that they think that those of us who are much older are very judgmental, unfriendly, and they prefer to have their fellow peers support them to receive care all through, from the point of entry into care when they test positive, through the entire treatment cascade, including prevention services. So we need to leverage on the peer-to-peer support. And we saw again that during the COVID pandemic, from the paper that was presented by Laurie, that one of the areas that we can leverage on is using digital solutions for our HIV programs, but also during public health emergencies. And one of the innovations during the COVID pandemic was that people were using digital platforms to continue to provide psychosocial support and peer support during the public health emergencies, so that those, the young people, even when they are not able to meet, they still continue to get that support from their peers. Yeah, thank you.
Thank you, Eleanor. There's a question from Dominique Ingala. And Dominique asks, what steps do country programs have to take to strengthen pediatric case finding? I think you talked about a number of the promising practices that were presented at ICASA. Can you summarize for us what those best practices are for case finding in kids?
Yeah, thank you very much, Dominic, for that question. And one of the key areas that were mentioned in the paper that was presented by Immaculate from Kenya were to ensure that we are using screening tools, especially at high volume areas like the OPD, ensuring that we expand HIV self-testing to children and adolescents. We can use caregivers to administer the HIV self-testing kits to their children, and also scaling up EID and leveraging on the primary healthcare programs that are already happening in our programs, like the immunization programs. So leveraging on those to ensure that we are scaling up early infant diagnosis, and of course in the older adolescents, utilizing assisted partner notifications and using their social networks to reach the adolescents and young people. Thank you.
Very good. I see no other open questions at the moment, but please feel free to post them into the Q&A box, and we can ask Eleanor to address them for us. The Q&A box is a little bit easier than the chat box, but if you can't find the Q&A box, then please do feel free to comment into the chat box. While we're waiting for comments to come in, Rike, can you remind us how colleagues can access the presentation following this webinar?
Yes, in a few days, we'll have it uploaded on our YouTube channel and on our childrenandaids.org website. So if you go to childrenandaids.org, in the top, there is a button pressing webinars, and they come in chronological order. So just go there in a couple of days. But for all of those that registered today, and I believe that should be all of you, you will receive an email notification once it's been uploaded. And
just, sorry, go ahead.
No, and we will post, of course, both the presentation from today, but we also have a longer slide set with more studies. We just had to make a selection for this webinar, but there will be a longer slide deck for everyone's disposition.
Very good. Yes, Eleanor, you did a huge amount of work preparing for this, and this was just a small sampling of all of the studies that you summarized and the papers that you looked at. I also want to clarify that the YouTube channel allows you to actually see this whole presentation, including the audio recording as Eleanor was making it. So it is often an easier way to review the material, because you have the benefit of actually having Eleanor herself talking through the slides. So I would encourage people to both access the slide set, but also review the YouTube link so that they can engage the whole presentation and benefit from Eleanor actually speaking to the slides directly. And I see that Rike has posted the links to our YouTube channel in the chat, as well as, of course, the childrenandaids.org web space, where you can get this and all of our past Learning Collaborative webinars. So while we're waiting for another question, Eleanor, forgive me for using the chair's privilege, but one of the previous speakers, one of the previous participants had asked a question about what the keys are to achieving 95% coverage, or more than 95% coverage. I think you reported at the start in the epidemiology section of the webinar that there were several countries that had reached high levels of coverage, exceeding 95%, and including some countries in West and Central Africa, where although the overall coverage was very low, at only 56%, there were some shining examples of countries that had managed to achieve very high levels of coverage. In your experience, both in your practice in Uganda and your knowledge of programs across the sub-Saharan African region, what would you say are the hallmarks of success?
Thank you very much, Shafiq. Very interesting question. Indeed, we need to ensure that we increase the proportion of children living with HIV who are accessing ART. And some of the things that I think should be put into consideration in our programs is ensuring that, first of all, the systems in our clinics are robust. We know that many of our clients are still struggling with disclosure of their HIV status. And many times when the mothers bring their children to the clinics, they have got a window to escape from home before the breadwinners or their husbands return home. So when they come to the clinic, they want to spend the shortest time possible and go back to the clinics. So we need to make sure that our systems are robust. First of all, to pick up those who are testing positive, to make sure they don't fall through the cracks. So we should have very good linkage systems from the different testing points to the HIV care points. And when they come to the HIV care points, we should make sure that our systems are able to fast track them through from the time they come to the triage to the time they leave. So that waiting time should be significantly reduced. So we should perhaps come up with particular desks or particular rooms where we send those who are coming for the first time, so that we encourage them to come back and they do not fall out at that point. And then very important as well is to ensure that at the point of the post-test counseling, the information that is given should not be just like routine or passing on information. Also, we've tested you and you're HIV positive. We should be able to understand that this person is still dealing with going through that phase of accepting their results. So they need time to digest this and be able to come into care when they are prepared and they have been able to understand that this is a lifelong kind of treatment. So that is very important. And for the adolescents, I learned recently that they want a safe space. They want a safe space, and I think this came out through one of the presentations that the presentation that was looking at the framework for patient-centered care, that they need their private space and they need their flexi hours. So they should be able to come in at times of convenience to test. And when they come in during those flexi hours, there should be someone who is still able to provide the ART services at that time. Thank you, Shafiq.
Very good. Eleanor, thank you very much for that observation. I think we are reaching the end of our allotted time for this webinar. So I want to thank you again for all the work you did in giving us this extraordinarily comprehensive overview, very elegantly presented and concisely presented as well. Thank you all to the participants who joined us. We look forward to hosting you again on our next Learning Collaborative webinar. Look out in your inboxes for the links to these presentations and for the YouTube channel that you can access to hear Eleanor speaking again. And with that, have a good day, everybody, and thank you very much indeed.
Thank you.
Thanks, everyone.